Hi everybody. So previously we were discussing the structure of the nephrons as well as the classification of the nephron. So we learned that the two main structures of the nephrons were the renal corpuscle as well as the renal tubules. And then we also discussed that there are two types of nephrons, and the first one would be majority of the structure would be located in the cortex. Therefore, we refer to these as cortical nephron, versus the second type of nephron, where majority of the nephron tubules will be located inside the medulla, basically at the junction of the cortex and medulla, and therefore we refer to those nephrons as juxtamedullary nephron. Now we're going to move on and discuss a couple of cells that are essential for the functionality of the kidney. But I just want to show you a quick picture. Something that when we show the structure of nephron early on, and I'm just going to go back for a couple of slides to show you something, and then we'll come back to this slide. Whenever we show the nephron earlier, the way that it was described was you have the proximal convoluted tubules, then descending limb, then ascending limb, and then distal convoluted tubules, which is emptying into a collecting duct. Now, the reality of these nephrons, the way that they are structured, it is still the same, but the way you present or position the distal convoluted tubules is slightly different. So let me show you this picture to clarify. So right here you have your glomerulus, which is basically packed inside the Bowman capsule or glomerular capsule to form your renal corpuscle. Then if you continue this, you see this part of the tube that is your proximal convoluted tubules, this region. Then you have your descending limb, fluid going down, then the ascending limb, and then you have the second part of the tubules, which you identified as distal convoluted tubules. But notice that the distal convoluted tubules is partially located between the afferent arteriole that is bringing blood to your nephron and efferent arteriole that is taking blood out of your glomerulus and out of your nephron. So if you zoom into this picture, we see the same thing. So right here you have your afferent arteriole. This is the glomerulus, efferent arteriole. This is your renal corpuscle. So connected to that, you have your proximal convoluted tubules, right? So imagine that you have the proximal convoluted tubules, then the tube is going to go down, and I'm going to show you in a very quick drawing. So basically what I'm saying is, basically the tube is going to go down, okay? Then it's going to come up. Let's put this picture, okay? And it's gonna poke its head right over here, which would form your distal convoluted tubules you see right here. Now, this is really important for proper functionality of your kidney. In this structure, we form we have two main type of cells, which I'm just gonna highlight for you guys right here. You have these kind of columnar cells that you have right here that are forming the wall of your distal convoluted tubules, and these are called the macula densa cells. And the second type of cells you have are cells you see right here that are part of the afferent arteriole, cells right here and right here, and these are referred to as the granular cells. So what are the functions associated with each? So juxtamedullary apparatus, which is basically what I showed you, is made up of granular cells, which is responsible for secreting renin. We'll discuss this in more detail, but renin is part of a system which we refer to it as RAS, renin angiotensin aldosterone system. And this is extremely important for absorbing sodium, removing potassium, and also through the same path, absorbing water. Macula densa, on the other hand, the lung cells that I showed you, they are part of the distal convoluted tubules, or your DCT, and Their job is to act as chemoreceptors to monitor your blood for different type of ions. And again, we'll discuss this in more detail when we talk about the fluid balance. Just something to keep in mind for now. Now, if you guys remember, we said that the structure or the organs associated with the urinary system starts with the kidney. And when urine is produced by the kidney, they get passed down to the long tubes, which refer to it as ureters. Now, a couple of things about ureters. Ureters have a lining that is made up of mucosa, or I should say, it has a mucosa lining that is made up of transitional epithelium. To kind of remind you again, transitional epithelium is a specific type of a stratified, a squamous epithelium. So basically what they are, these are the ones that transition. So normally they're kind of thick, more cube shaped when ureter is empty. And as you start to go and push urine through it, you need to expand the size of the ureter so the cells become a little bit flat to basically stretch out the tissue. So if I ask you what type of cells make the ureter, your answer could either be transitional epithelium, if it's very specific, or stratified squamous. Now you also have two type of muscles, which is the muscularis layer. You have the inner part that is close to the transitional epithelium is longitudinal smooth muscle, and the outer layer, the second layer, is circular muscle. Remember, both of these are a smooth muscle. And then surrounding your tissue, you have a layer of connective tissue, which we refer to it as adventitia. Now, ureter is going to transfer the urine to the storage of the urinary system, which is the bladder. Bladder, you do need to understand, it's a collapsible sac, which means when basically bladder is empty, the two layers are kind of flattened out, and as you start to fill it up, the size starts to expand. So in a full bladder, the shape would be more spherical rather than a collapsed sac. An empty bladder lies entirely beneath the pelvic region, and in the case of male, the urinary bladder, inferior to urinary bladder, you have the prostate gland. So let me just show you this quick picture. So this is a male and female reproductive system. A couple of key points you guys need to know. So here is the bladder in the case of male, and this is the bladder in case of female. So in the case of male, the bladder, right underneath it, you have this circular structure right here, which is the prostate gland. In female, however, we have this muscular structure on the top, which is the uterus. So starting with female, when female gets pregnant, as the baby starts to grow, it starts to push down on the bladder and basically limits how much urine a bladder can hold. Hence, pregnant women, as they go through their pregnancy, they really require to use the bathroom relatively frequently. In the case of male, however, you have the bladder and underneath you have the prostate. Now remember that there is a tube that goes from the bladder down all the way and opens up to the outside, which we refer to it as the urethra. So prostate is actually surrounding the urethra as it passed through it. So in men, a lot of times the problem arises with their urinary system as they age, is the prostate starts to get larger, so basically enlarged prostate, and that causes basically the thinning out or limiting the diameter of the urethra, making it relatively hard to urinate. So now that we're talking about the urethra, something to keep in mind, urethra is also made up of transitional epithelium, but it's more closely to the bladder region. So if you want to keep in mind, both ureter, bladder, oh, sorry guys. So ureter, bladder, more specifically urinary bladder, because we also have gallbladder, and first of urethra are all going to be what? Transitional epithelium, which we identified as stratified squamous epithelium. Now, as you start to go down, you can see that the cells become more stratified or pseudo-stratified columnar, somewhere in the middle. And when you get closer to the outer edges of the urethra, it becomes a stratified squamous with the goal of protection. So in this case, the goal is not to stretch, is rather is protecting because it's opening up to the outside. Lastly, for the urethra, do remember that it has two separate sphincters, which are basically circular muscles that control the urine release. The internal one, which is also true for the anus, is made up of a smooth muscle, which basically means this is under your nervous system control and you have absolutely no control over it, hence the word involuntary. The external sphincter is basically what allows you to control your urination. So it's made up of a skeletal muscle, a skeletal muscle, and basically it's what gives you again the ability to urinate. So urethra in females, if you guys saw the picture, I'm just going to go back and show you quickly. Urethra in females starts from here and ends right here, is about 3 to 4 centimeters. In males starts from here and it goes through the length of the penis, so it's relatively longer. So in relation, length of the female urethra is about 3 to 4 versus the male urethra, which is about 20 centimeter. In males, we actually have 3 segmentations for the urethra. If it is passing through the prostate gland, it's called the prostatic urethra. If it's passing through a membrane or a diaphragm called urogenital diaphragm, we refer to this as membranous urethra. And as it passes through the length of the penis, it's referred to as either penile or a spongy urethra. And you'll learn more about this in 251 when you review the reproductive system in more detail. One of the very common type of infections associated with urinary system is UTI, or urinary tract infection, which is mostly made as a result of a bacterial infection. And something that is not listed, but I do want you guys to know, women are more susceptible to UTI. And the reason for that is, first of all, is short urethra, which means it's very easy for the bacteria to find their way up the urethra and get into the bladder to cause infection, versus passing through the urethra in male, which is about 20 centimeter. It's a much harder entrance point for bacteria. And the second thing is the proximity proximity of urethra to anal canal or to anus. So basically, for men, that distance is much farther versus in females. So a lot of time the bacteria that are present in the fecal matter can find their way to the urethra and also cause infection. That being said, it doesn't necessarily mean that men are not going to get UTI, it's just the percentage would be much smaller. Do note that the symptoms of a UTI is burning sensation during micturition and also frequent urination, or the assumption that you want to go pee, but you don't really need to. It's really good to take, when you're diagnosed with UTI, do not let it just sit by itself. Make sure you take your antibiotic medication, because UTI can spread far up through the ureter and affect the kidney and cause major damage to the kidney. Another medical condition is renal calculi, which is basically kidney stones. We'll discuss this in more detail in the second PowerPoint. And same thing as UTI. You have more detail on this, the same on the UTI on the next PowerPoint. And lastly, we have kidney cancer, which is typically associated with the epithelial cells. We didn't talk about uriniferous tubes, but just understand that they are rising from the tubules within the nephron, and they basically advance and spread throughout the rest of the kidney. We will discuss some of the more common medical conditions of the urinary system later on through the PowerPoint as well. Now, that was basically the anatomy of the urinary system. So we're going to move on to talk about the physiology of the urinary system. So when we're talking about urinary system, almost 99% of the function is done by the kidneys, because kidneys are the structures that are going to be producing the urine, which basically is responsible for filtration of your blood. So what gives you the ability to produce urine? So urine is actually made up of three stages. The first one is known as the glomerular filtration, or simply filtration. And then you also have tubular reabsorption and tubular secretion, or you can just simply refer to them as reabsorption and secretion. But just looking at these words and making sense of it, you can understand that when we say glomerular filtration, that implies that filtration takes place in the renal corpuscle and is associated with the glomerulus. And when we talk about reabsorption and secretion, and we use the word tubules, it implies that these two processes are taking place within the renal tubules, which is basically proximal convoluted tubules, descending and ascending limb of the nephron loop, and the distal convoluted tubules. Collecting duct also plays a role in it, but we don't really consider it as part of the nephron itself. So let's start by glomerular filtration. Glomerular filtration is a passive process that basically allows the molecules to move from the glomerulus, which is a capillary network, very leaky, to move from the glomerulus into your renal tubules. So what determines what molecules are going to pass through and what molecules stay behind? The biggest determining fact is the size of these molecules, right? There's no force in a sense of putting energy into this, because this is a passive process. So the only determining factor for what gets filtered is the size of the molecules that are present inside your blood. So before we go into that, I just want to kind of quickly go over one thing and look at, sorry, I thought I had a picture of it. But I'm going to draw a picture right here. And let's look at the components that can be found inside your blood, okay? So the component of your blood was plasma. We already remember this, right? And you have red blood cells, and you had white blood cells, and you had platelets, right? And within plasma, we mostly had water. We had ions, which include sodium, potassium, chloride, bicarbonate, hydrogen ions. We have the waste product, which in this case we're talking about urea, uric acid, creatinine. We have glucose, which is basically the molecules needed for your energy. And then we have also amino acids, which are freely flowing in your blood to be utilized by your cells to make proteins. Now, the next question we have is, which of these components are going to be small enough to pass through versus large enough that they're going to basically get stuck. Oh, sorry guys, I forgot one more component, which is proteins. Remember we have albumin, globin, fibrinogen. So do you think water is going to be large enough or small enough to pass through? Yes, because water is made up of what? Two hydrogen and oxygen, which is really a small molecule. So water has the ability to be filtered through because it's too small. Same concept applies to your ions, including bicarbonate, because these are small enough that, again, it's the single sodium or single potassium. So they also can pass through. Waste products such as urea and uric acid also are small enough that can pass through. Glucose is also small enough. Amino acids are also small enough. But think about the protein, guys. Proteins are made up of hundreds upon thousands of amino acids. So I might be able to pass individual amino acids, but if I have many amino acids stuck together to make my protein, that structure will be way too large and will not pass through. So protein will be out. Now remember, red blood cells is a cell that is packed with 250 million globin proteins. So if I can pass one protein, would I be able to pass something that has 250 million protein inside of it? The answer is no. So red blood cells is out. White blood cells. If you guys recall your histology, white blood cells typically appear larger than even red blood cells. So if I can pass red blood cells, I cannot pass white blood cells. So that's out already. And same thing with platelets. Platelets are also going to be large enough that they will not pass through. So by just looking at this picture, you notice that the components that are going to be filtered are what's associated with your plasma, and that's basically water, ions, waste, glucose, and amino acid. Now do keep in mind that if your glomerulus, the capillary network that is within your renal corpuscle, responsible for filtration, if it is damaged, then it does allow red blood cells, white blood cells, and platelets to pass through, and they eventually be visible in urine, and you will test positive for RBC, WBC, and platelet. But if you are a healthy person, and there is no damage to your kidneys or your glomerulus more specifically, then white blood cells, red blood cells, platelets, and proteins should be absent in your urine sample. Now, lastly, I'm going to just finish up by the pressures that are driving force for the filtration. So there's three different pressures that are working to make the glomerular filtration happen. So it looks complicated, but it's really easy. Hydrostatic pressure is just the pressure that water puts on the membrane. So if you look at this, it says we have a hydrostatic pressure that is associated with the glomerular capillary, or more specifically your glomerulus. And then as you push fluid out into the PCT and into the Bowman capsule, you're also going to have fluid in there, so those fluids also going to push back. So that would be referred to as the hydrostatic pressure in capsular space, which basically is space around the glomerulus. So we call that HPCS. Now, if you guys recall from osmotic pressure from back at the beginning of the semester, osmotic pressure was the pressure of solid molecules, or I should say, is described as pressure or pull solid molecules have on water. So recall, you have a lot of components in your blood. You have red blood cells, white blood cells, platelets, proteins, amino acid, glucose, ions. All of these want to do what? They want to pull the water back into the glomerulus rather than keeping it inside the capsular space. So in a sense, if you look at the picture, I'm just going to show you the picture, guys. If you look at the picture, let's orient yourself. You have afferent arteria, you have the glomerulus, right? and then efferent arteria sending blood out. So these are the three pressures that we're discussing, guys. Hydrostatics of the glomerular capsule is really strong because the driving force for this is basically your normal blood pressure, because it's coming from the afferent arteriole. Afferent artery is connected to all the other blood vessels, which comes from the renal artery, and renal artery is connected to aorta, and aorta is connected to your heart. So the main driving force, where should we say hydrostatic pressure here, that 55 millimeter of mercury is associated with your heart basically pumping to maintain pressure in your arteries. Now, we have fluid, so as you push fluid out this way, you're going to have fluid in this space, right? The capsular space. So these fluid that are here are also going to do what? Push back into the glomerulus. But one side I have my heart, this side is just the fluid itself that is pushing back. So the number is going to be much smaller. So that's only 15 millimeter of mercury. Now, osmotic pressure. Remember, in your blood, you have a lot of solutes, red blood cells, white blood cells, proteins, amino acid, ions, bicarbonate. All of these are happening and are present inside your blood. You have those components here, well, some of them here, but at a much smaller numbers. So the osmotic pressure that's going to pull water back is stronger going this way, right? So it's about 30 millimeter of mercury. So in a sense, you have one main pressure pushing out and a smaller pressure pushing fluid back in. So we take 55, which is the pressure pushing out, and then subtract it from the addition of the two forces pushing back in. So 55 subtracted from 45, which is the addition of these two, and that gives you what? 10 millimeter of mercury, which is the pressure that basically pushes fluid out to the capsular space and into the PCT. That is a normal pressure in a healthy individual. Can that pressure change? Yes. We will discuss it in more detail later on, but that pressure can increase or decrease to basically monitor or change the flow of fluid into your PCT. But that's going to be your next lecture. So just quickly, tubular filtration component that comes out into the PCT is referred to as filtrate because it's been filtered, and it includes water, all of your ions, urea, which is an example of a waste product, amino acid, and glucose. And again, notice components such as red blood cells, white blood cells, platelets, and proteins are missing from your filtrate because they're going to be way too large. Okay, guys, so we'll continue with the PowerPoint on the next, we'll continue with your presentation in your next part of the PowerPoint.